is by Dr. Rich Lindrooth from the Colorado School of Public Health on using the tools of financial management to make a business case for value-based interventions. Go to the next slide there, Jordan. And then upcoming next month, Dr. Demetria McNeil will be presenting on value proposition design. So the use of value propositions, not just for the business world anymore, lessons for program sustainability. This is sure to be really interesting. A great talk on how to communicate your value to healthcare organizations. That'll be next month. We're also really excited about this year's Colorado Pragmatic Research and Health Conference, or CopperCon. Our registration is now live. And if you go to our website, just follow the go to coppercon.com, and it'll take you to our website, and you go to the registration and see about registration options. If you are a student, staff, or faculty member from the University of Colorado Anschutz Medical Campus, or any of the affiliate institutions of the Colorado Clinical and Translational Sciences Institute, or CCTSI, you can register for free. You have subsidized registration. And there's if you Google affiliated institutions for the CCTSI, you can see who's listed there. It's things like Kaiser Permanente of Colorado, Colorado State University, the VA of Eastern Colorado. They're all affiliate institutions. But then anyone else, it's $149 before April 2nd. And we have 2 tracks this year, one focused on dissemination implementation science and one on biostatistics and data science, but both are about implementation and conduct of pragmatic research. So how do you actually work with real world healthcare settings and real world data for conducting your research? We have a number of really fantastic keynote and plenary speakers planned. You can see them listed here. Next slide. We also have a call for abstracts for CopperCon. And so if you'd like to submit an abstract to present a poster, we are doing a virtual asynchronous as well as poster walk session this year. And so there's 3 theme areas, one on pragmatic trial or pragmatic research examples, one on dissemination implementation science methods, and one on data science and biostatistics methods for pragmatic research. And so pragmatic research is any research in working with real world settings, and abstract deadline is March 29th. And more details on our website. I just want to make sure at the conclusion of this seminar that you complete our evaluation. You should be getting this link, I believe, in your email as well as in the chat. Towards the end of the seminar, we'll leave a few minutes. So please plan to stick around and do our evaluation. And people always ask, are we going to record this? Absolutely, we'll be recording it. It'll be available on our Accords Education archives. I think that's it. So I will introduce today's speaker. So Dr. Richard Lindrooth is a professor and co-director of the Health Service Research Doctoral Program in the Colorado School of Public Health. His research is focused on health economics and health policy, with an emphasis on the economics of the hospital industry, health services research, Medicaid and Medicare policy, the delivery of mental health services, and access to care. His research has been funded by the National Institute of Mental Health, the NIH Common Fund, the Agency for Healthcare Research and Quality, the Robert Wood Johnson Foundation, and the Colorado Health Foundation. He received his PhD in economics from the University of Washington and BA in economics from the University of Vermont. So we are delighted to welcome Dr. Lindrooth today to talk about business models. So Jordan, who's going to share the screen? Rich, will you share your screen? Or
yeah. Thanks, Beth.
Okay. All right, thank you.
I'll go ahead and share it. There we go. Hello, everyone. So I'm going to talk about, actually, it's going to be 2 different ways of, sorry, one moment. There we go. Of understanding the impact of potential new intervention. So there's really 2 approaches. One is called budget impact analysis. And this is something that's done, it's complementary to cost effectiveness analysis. And it's commonly done, for example, if you have a new drug and you're considering putting it on a formulary, where you measure just the impact of including that new drug on your budget. And so Marcelo Perrion actually presented in this seminar a few months ago, and I was looking through his slides, and he did include a slide on budget impact analysis. And like I'm saying, it is part of cost effectiveness analysis, but complementary. However, for financial decision making, pro forma financial analyses are generally conducted. And so this type of analysis is different in that you're looking at an investment or a fixed cost that you put out, say at the beginning to get something up and running and set up. And then you look at the benefits of that investment over time. And so the pro forma financial analysis is you could compute the return on investment. It is possible with the pro forma, whereas it's not with budget impact. And so it tends to be a more common way of understanding the financial implications as part of a business case. So with a budget impact analysis, it's really designed to measure the impact of interventions on national, regional, and local health plan budgets. It's from the perspective of the decision makers, the person who's responsible for the budget. And it is required by some countries that tend to be ones with a national health system. So England and Wales are requiring it along with a cost effectiveness analysis when considering adoption of a new drug. It's also required for pharmaceuticals in Australia as well. There's a good summary article by Joe Moskoff in Value of Health that came out in 2007, which really goes through the detail and provides a recipe on how to conduct these. So I'll just summarize the key points of these. So comparing the budget impact analysis to cost effectiveness analysis, I found this slide actually in the Health Economics Resource Center at the VA. So the perspective is different. Again, with budget, you're considering the payer, the one who's managing the budget or responsible for the budget, whereas cost effectiveness analysis tends to be from the societal perspective. So it looks at the direct and indirect and long-term impacts of an intervention. Whereas the time horizon for budget analysis is short-term, so it may be 1 to 3 years. An important element of the budget impact analysis is the size of the population. Whereas cost effectiveness analysis, you're really looking at the average person, the typical person. With budget impact, you're multiplying that average cost by the number of people who would get the intervention in your health system or your insured population and so forth. The inputs really depend on the payer. They're specific to the payer in the budget impact analysis, and it only considers cost. And so it is complementary to the cost effectiveness analysis. And so, outcomes are an important part of the decision making, but for the budget impact, you're really just focused on cost. Cost effectiveness analysis also uses discounting so that future costs down the road, could be 5, 10 years in the future, are discounted, so they're reported in current dollars. And then overhead costs would be included in cost effectiveness analysis, but tends to be left out of budget impact. So this is a schematic from the Joe Moskoff paper. So the current environment, so the status quo, you have the total population, then given the incidence and prevalence, you figure out the sick population who would be exposed to treatment. Then the target population would be among those who actually became treated. Then you look at the resource utilization.
Rich, I'm sorry to interrupt. We're having a little bit of audio trouble with it going in and out. I don't know if there's, any tricks you have up your sleeve for that. Just letting you know that we're having a little trouble.
Oh, okay. So it's okay. Well, I'll try to speak louder. see if I turn this up a bit.
All right, thank you.
Yep. And so on the left-hand side, you do have the current environment, and you go through these steps and figure out the cost of illness. And again, this is for the entire population within the payer or system that you're looking at. And then the budget impact is based on the new environment, so the new intervention, and you go through the same steps. The population, sick population may be the same. The target population may vary depending on how the intervention is different than the status quo. But again, you just figure out the resource utilization and cost to estimate your cost of illness. So the impact would be the difference between the status quo and the new environment. And so things to think about when designing these. One, is it treatment for a chronic or an acute condition? And this helps you determine what the unit of analysis is for your cost. So if it's an acute condition, an episode may be more appropriate in that the intervention is finished right away and there's not a long-term cost implication. Whereas a chronic condition, it may be more appropriate to use the patient and track them over time as well. You also consider the type of intervention. Is it preventive, curative, palliative? This gives you an idea of what costs to collect and over what period. And then you consider the expected uptake. So how many people will actually be treated? What about compliance and adherence to the treatment? These can have significant impacts on the cost. And then you perform a sensitivity analysis, and this is an important part. You may vary the compliance and adherence or the number of clinicians that uptake the new procedure or new approach to give a range of estimates. And finally, the last design element is how do you compute? And so I think the most common, and it's also the most straightforward and easy to understand, is a deterministic calculation. So you just add up the numbers and then treat them as fixed in each time period. And so this is similar to the calculations you would use if you're creating a budget. However, it can be more complicated, just like in cost effectiveness analysis, Markov chains, agent-based modeling, more stochastic, time-dependent approaches can be used if it's appropriate. Obviously, this would be more for a chronic condition where there's a trajectory over time where you'd want to track people and figure out the costs. The perspective is very important. Again, it's the decision maker who's responsible for the budget. And so you consider who's paying for the intervention. Is it the insurer, the health system, or the patient? And so if there is an out-of-pocket cost to the patient, for your institution or a health system, you wouldn't consider that out-of-pocket cost because it doesn't influence your budget, for example. Whereas with CEA, you would consider the overall societal benefits and the welfare of the individual patient. So for example, if you're considering an UC Health, what perspective do you choose in terms of adopting a particular intervention? It really depends in part on who's deciding. So if it is the department's decision and they're looking at the department budget, then you just look at the impact at the department. However, some interventions have spillovers upstream and elsewhere in the health system. So for example, primary care decisions may impact specialists or a hospital down the road. However, if you're looking at the department perspective, you only care about your budget. But it may make sense if you do have these spillovers to also look at it from the health system perspective and the overall benefit versus the benefit for an individual unit. And so some of the other elements of the budget impact analysis, you need to consider the scenarios. So status quo would be your reference or base case. And then there may be more than one type of intervention that you're trying to choose among. It may be in addition to the current treatment as well. So these are things to think about. Your goal is to, again, look at costs in the base case, and then the costs in the new world with the new treatment or the intervention. I can't stress it enough, population is the key number. That's where most of the variability is. So you do need a good estimate of the number of patients who are candidates for the intervention, and also consider uptake among the clinicians or other individuals in your organization. In some cases, adherence by patients can be an important element, if there's follow-up care and so forth. Then finally, the subgroup analysis is also tends to be included. So it may be that the intervention is most effective for a certain group of patients and should be a first-line treatment for that group of patients. However, another set of patients, it may be more appropriate for a second line. You may use something less expensive initially and then follow up with the new technology as the second line. So consider looking up subgroups by age, sex, disease severity, and then measuring the impact on those various potential groups in order to inform potential decision-making. Then the time horizon, the results are presented year by year over time, so discounting isn't used. And yeah, so leave it at that. So with the costs, so it is all costs relevant to the health condition over the time horizon. So in contrast to cost effectiveness analysis and ProForma analyses, you use actual expenditures. So what's expected to accrue, you don't use opportunity costs. So you figure out the relevant transaction prices, netted discounts. And these tend to be short-term, so it only includes variable costs. So the cost of treating each person over time, and does not include overhead or fixed costs. And then reimbursement for the intervention. So if you are reimbursed, or you could actually charge more than the status quo, then that will serve to offset costs. This is something that's not included in cost effectiveness analyses, but for the budget impact analysis, it would be an important component. So I'm going to switch gears to the ProForma financial analyses. And this is the goal of these analyses is to examine the impact of a project or intervention on the financial health of the organization. So it goes beyond just the budget. So it's looking at the entire organization. Does the change enhance the financial performance or detract from the financial performance? These type of analyses are done when there's some upfront cost or investment. And they're often done, say you have some capital funds, you have the ability to invest in a variety of equipment or processes and so forth. So you're trying to figure out which one would be the best use of your funds. And so you have this outlay of money and investment, and then it's offset in the future by improving cash flows. And so at the beginning, you're paying money, and then over time, the intervention will yield profits, if you will, positive cash flows that will offset the initial cost. And so one example that I used, and this from a paper that I published a few years ago, is the decision of whether or not to become a magnet hospital. So this takes a lot of work. It's costly to achieve magnet status. You have to invest in training. You may have to hire new people to meet the staffing ratios and so forth. And so given this expense, is it worth it? So could you go to the CFO and say, yes, we should do this? Though it costs money initially, over time, it will pay for itself. So to do this, first step and the major step is to estimate the project's cash flows. So the initial investment would be the fixed costs. So this would be all expenses incurred to purchase equipment or to implement a new processes or procedures. It may be training, investment in IT systems, and equipment. So whatever it costs to get something up and running. And then once it's in place, you measure the variable costs. And these are all incremental. So what is the additional cost relative to the status quo? Also the revenues. What are the revenue impacts from this investment? And so you track these over time. And again, it's incremental. So it's incremental to where you currently are. It does not include sunk costs. I, for some reason, wrote sunk costs. So sunk costs, meaning costs that have already been incurred, and that you would essentially will have paid those costs regardless of whether you had the intervention. So they're not incremental costs. And then there's a terminal cash flow, which would be at the end of the time period. And then in some cases, like with equipment, there may be a secondary market that you could sell the equipment. So it has some value at the time period that needs to be considered. Or in many cases, you just truncate the time horizon, say at 10 years, 15 years, and then calculate it. And then the final step, so once you have all this in hand, you can calculate the return on investment, which is essentially the discount rate that sets the future benefits equal to the current cost. And so there's actually a function in Excel called the internal rate of return that is used to compute the return on investment, or the ROI. And so it's used in decision-making using the average return on capital of the organization as a benchmark, in a sense, a hurdle. So if the expectation within your organization is that investment should yield at least 10% ROI, then if your ROI is greater than 10%, then it will improve the overall financial performance. If it's less than 10%, then it would detract from your average financial performance. But it's not necessarily a bad thing, because this is just one number, and other things should be considered: strategic, mission, and also the confidence that you have in your inputs or your result. So it's really just one piece of information within the decision making. The benchmark return on capital should be risk adjusted to reflect the inherent riskiness of the project. So you'd want a higher benchmark for a high risk project, reflecting the risk return trade-off. Like with cost effectiveness and budget impact analysis, the perspective is extremely important. Like I was saying before, it may look great from the department perspective, but if there's cannibalism of other departments, then from the health system perspective, it may not look as good. And another element of ProForma financial analysis. So in order to calculate return on investment, you need to have that return. And so you need to have an increase in revenue to offset both the ongoing costs as well as the initial investment. And so you do need that increase in revenue in order to calculate the ROI. If you don't, then it's really a matter of really understand the cost implications. And it's actually more similar to a budget impact analysis at that point, because there may be qualitative reasons or mission related reasons to move forward. even if it doesn't result in an increase in revenue. And so one example is with quality improvement activities. It may not have an immediate revenue benefit, but there may be indirect benefits through improving reputation, which could lead to, in a hospital situation, more admissions, or even higher payment from private payers. So you may have these indirect benefits, but it's not, in most cases, you don't have, say, P for P, where you get an increased payment related to your quality improvement effort. It's really more indirect through enhanced reputation, so forth. And so that's kind of what we were getting at in the medical care paper, is what are the longer term benefits of magnet status. You can advertise and say, yes, we're a magnet hospital. This is a good thing. You could expect high quality at our organization. And then understanding the longer term revenue implications of achieving magnet status. But that is just one element of the decision to become a magnet. There may be strategic considerations, and we actually included this as part of our analysis. So you are competing with other hospitals in the market. If other ones became a magnet, it may put you in a worse position. So you may have to keep up with the Joneses, if you will. And that would provide you another reason, a strategic reason to become a magnet. And then you also have to think about where the industry is going. And you do want to keep up overall. So in this paper, the word business case was actually in the title. So is there a business case for magnet hospitals? And so we estimated the cost and revenue implications. So to become a magnet is expensive. It takes on average just over 4 years to attain status. There's a large investment in staffing, processes, and structural changes in the working environment. And the estimates that we found when we wrote this paper is that it costs anywhere from $100,000 to $600,000 per year, depending on the size of the hospital. So it is a significant investment up front, and that's per year. So over 4.25 years, you get into the millions of dollars if you're a large hospital. So the question is, does it provide financial benefit? So from the financial perspective, is it worth it? And so there are the well-known costs for increasing staffing ratios. For example, you incur higher labor costs. But the question that we were trying to get at is there a revenue benefit? So is there this indirect benefit through having this signal of high quality by being designated a magnet? So do you attract more patients? And also, do private insurers reward you for the higher quality? So the private insurers, the idea is that they're forming a network, and then they take that network and go out and market it to individuals and companies. And if you have this magnet recognition, it makes that network more valuable to the insurer. And so that could lead to higher reimbursement compared to if you weren't a magnet. And so then the insurer, their plan is more popular with employers because they have this magnet hospital in their network. And so we examined this looking at hospital level data of costs and net patient revenue, and estimated what's called a difference in difference specification, where we compared hospitals before and after they achieved magnet status to a group of hospitals that was otherwise similar but did not attain magnet recognition. The challenge of this is it's not random. There's certainly a selection bias. So we used 3 approaches to control for selection bias and assessed whether or not the results were similar or robust. The first is hospital fixed effects. So this would be a dummy variable for each individual hospital to control for all time invariant confounders. So it could, within the sample period, if management's fixed, it controls for management quality, for example. We also used instrumental variables, which was whether or not the hospital's competitors were magnet hospitals. The idea being that you'd be more likely to seek magnet status if your competitors were also magnets. So that'll help you compete in the marketplace. And then at a referee's request, we also computed propensity scores. We used matching in addition to stratifying. We felt that it was a case where it was selection on unobservables, things that we couldn't observe. So initially we didn't do a propensity score. The reviewer asked us to. So in order to get published, we went ahead and did it. So the primary results, we found that after becoming a magnet, costs increase about $193 per discharge. But there was also a revenue increase on average $320 per discharge. So on net, the hospital was making about $127 more per discharge than they did before becoming a magnet. I would say that the net income estimate was not significant, whereas the changes in costs and revenues were statistically significant. But the fact it's not significant implies that it doesn't make you worse off per se, but it could have implications for a ProForma financial analysis. So I'm going to conduct one as an example real quick. So in practice, if you're looking at one hospital, you would be collecting the costs, the incremental costs from the intervention, from the effort. We're using a top of the tree type approach. So we look at the incremental costs in aggregate rather than building up individually. So I'm going to assume our target hospital has 9,000 discharges, which is about the mean of our data. And so with 9,000 discharges, income would increase 1.1 million per year. The initial cost, assume 500K per year, and then it takes 4.5 years to roll out. So the total investment is 2.25 million. So the question is, what do you get for this 2.25 million? And then eventually, in the longer term, the cash flow is improved by 1.1 million. So to conduct these, the key element is your time horizon. And what I do, this is when I teach financial management, especially, I always write down the timeline. And so you know, okay, year 0 is the present. And so we're saying, first year, the hospital would invest $1 million. And then after that initial upfront, it still costs about $250,000 per year. So I'm assuming no effectiveness until you attain magnet status. So let's say halfway through year 5, you do become a magnet. And then the returns start to come in. So initially you only make 200,000, but then over time you get into a steady state and make 1.143 additional dollars per year. And then the bottom line here computes the net cash flows, and so you sum up. If we're doing a bottom-up type approach, there'd be a lot of lines here for the costs, and then a few lines here for the revenue. And so given this example, the ROI calculated using the Excel's internal rate of return function is 12%. And so that would be the rate of return, and then you'd compare to the benchmark cost of capital. So if your benchmark cost of capital is 15%, then you know that while this investment is paying for itself, it's not, the rate of return isn't equivalent to what would be expected for the organization. And so if it's less than the benchmark, it would detract from financial performance. But again, the financial performance is not the only thing that you make decisions over. There are strategic, mission, other elements that are important in decision making. One thing with both the budget impact and the ProForma financial analyses, it's really important to do sensitivity analyses. It's always the case where some of the inputs are difficult to measure. You may not have confidence into the accuracy. And so you should vary them and understand how that input influences your results. Then you report a range, and it can be under a variety of scenarios as well. As I mentioned, financial impact is only measures the financial elements of the organization, but mission is important as well. And then the key element in order to get a ROI is that you need that incremental increase in reimbursement. Otherwise, the return on investment actually cannot be calculated. And so the key element is that you do have incremental increase in reimbursement. So maybe that payers pay more. That's certainly happens with drugs. It doesn't happen as much with processes and redesign that may improve quality, but it's not directly reimbursed by insurers. And one thing to consider is to do an analysis from the insurer's perspective in order to maybe convince them to reimburse more directly for a certain type of intervention. So just to summarize real quick, perspective is everything. It's of critical importance with all of these types of analysis. The incremental element is also very important. When I used to work at the Medical University of South Carolina and was on a committee that evaluated proposals for new pieces of equipment. And then inevitably, they all looked really, really good. But the problem was they didn't focus on the incremental changes in costs and revenues. It's really important that you look at the changes and not absolute revenues, especially. Budget impact analysis, it's more, for planning, just like budgets, what the implications are. It's not conducive for ROI. So depending on the situation, it may or may not be included in a business plan. With ProForma, it is a key element of a business plan in reporting the financial performance and the implications. But again, it's meaningless if there's not an incremental improvement in cash flows. So initially I was asked to talk about the financial sustainability. And I think one take-home point is the sustainability or the long run implications of an intervention depends on whether or not it does improve cash flow. And certainly, though it obviously seems obvious, but if it does improve your revenue, it's more likely to be sustainable. And so these tools can be used to evaluate the longer run financial impact of intervention, and also can be used to choose among different options going forward. And then again, as I said many times, it should be considered in the context of mission and other non-quantitative or qualitative elements in order to arrive at the final decision. All right, I'm happy to answer questions.
All right, thank you so much. We do have a few questions, and just a reminder, if you do need to hop off at some point, please do our evaluation. It's very important to us. And so if you have questions, you can enter them into the Q&A section, or you can put comments and questions in the chat, whichever you prefer. So our first question here is, can you help us understand a little bit more the difference between a budget impact analysis and a cost benefit analysis?
Yes, I think the key difference is that the cost effectiveness analysis does consider outcomes. So essentially you're gauging whether or not the improvement in outcomes is worth the additional cost. And so say you do a cost effectiveness analysis and you find, indeed, from a societal perspective, it's a good thing, we should go forward with it. So now you want to go out and get it adopted. And so say you're in the VA, for example, and you say, okay, we did this cost effectiveness analysis. It's a great intervention. We think we should use it system-wide. And the VA says, what? Wait, that's expensive. It's going to cost money. So they're going to say, what's the impact on the budget? So that's when you do the budget impact analysis. You say, it is cost effective, but still it costs more. And so you pay for those better outcomes. And so you do your budget impact analysis and say, yeah, but the veterans care will improve by this much. We got so much better outcomes. It's going to cost the VA an extra $2 million per year. And so you're making the case to the VA that it's worth funding. And then also that they could have the overall funds, that the overall impact of the budget is something that could be paid for without going into a large deficit.
So I'm hearing you say that a budget impact analysis is, how much is this going to cost me? And then they need to make a decision as to whether the benefits, the improved quality, whether that's important to them, whether that's something that justifies the additional cost from a societal perspective or from a policy perspective, potentially.
Yeah.
All right.
Yeah, exactly. So it projects the cost benefit analysis for like your average person. The budget impact is based on the number of people who would need it. And so if it's something that affected all veterans, it'd be really large. It'd be smaller if it's for a specific disease or diagnosis. And then I see the next question about in-kind volunteer contributions. Short answer is no, they wouldn't be included in the budget impact. So it's really focused on the line items in your typical budget or your typical costs. And so if you need additional in-kind volunteer contributions in order to successfully implement the intervention, you'd only include expenditures that it takes to recruit the volunteers, manage them, train them, etc. So it's really just incurred expenditures, just like you'd have in a budget.
Okay. All right. One more question here. So we have a lot of projects where the status quo or comparator group is not easily identifiable, or it's sort of distributed. So for example, in a hub and spoke model, there may be numerous providers, et cetera, coordinating care for one patient. What are your recommendations for what to do when it's difficult to identify the comparator group? Or maybe it's multiple comparator groups, different perspectives.
Yeah, that's a tough one. So I guess ideally you'd go back to the time before the hub and spoke model, but it sounds like in this case it may be too late. That's a good question. I wonder if so in a sense, it's, as I understand it, it's already implemented. So you're, in a sense, your status quo is this care coordination model.
It might be something that, has so many different components that maybe you can really only look at it from a payer's perspective or from one provider's perspective, and then maybe look at sort of the average across all the different providers or entities involved, that there's sort of a collective, I don't know.
Yeah. So if you, so in this case, the unit of analysis would likely be the patient. And so in the current state, you could figure out the costs incurred for treating that patient. Yeah, I think that, in this case, it may be inside out, where you go back to the case where one provider is providing the care and estimating the costs associated with that type of model. So in a sense, your predictions would be based on taking away the current model in favor of a traditional model where there's one provider linked with one patient. That's yeah, so you do need something to change, and in this case, it'd really be taking away the system and then assessing the difference between the two.
In the chat, there's a question asking, so budget impact analyses sound a bit like a net present value calculation you might do on a piece of income producing property that has an initial cost to purchase. Is that sort of a good metaphor or analogy for that?
Yeah, I'd say the ProForma analysis is, it is analogous to calculating the net present value of future cash flows. And so certainly with the ProForma and the budget analysis, it really does ignore discounting. So you're just really thinking about the dollar amount that would change in future years. And then the decision making is whether or not the organization could afford these new costs.
Okay. All right. Do you have any other questions from the audience? Can you go towards, I think, your last slide, towards the end?
Yes. Yeah. Went too far. One sec.
You might need to share your screen again.
Yeah, it's not letting me. Okay, now it's letting me. Okay. Okay. Summary slide?
Yes. I know what it was. So what does it mean where you say here that it's meaningless? Can you explain what meaningless means from in this context?
Yeah, and so you need the initial cost, the initial investment needs to be offset by future profits, if you will. And so in the ProForma analysis, if it's all costs, then it's not possible to calculate the ROI. And so it's a meaningless calculation. You could still calculate the net present value of the negative cash flows.
Mm-hmm.
It give you an idea of the total cost to your organization.
Okay.
But the ROI isn't possible unless you have that offsetting.
And in your table that you showed with that 10-year time frame, I mean, presumably, the hospital would need to decide by what point would they need to start seeing a profit. But presumably that would be their decision. And if they say we can wait 20 years to see a profit, does that get taken into consideration?
Yes, yeah, it definitely is. So you can change the timeline. And I didn't cover this, but you could also compute the break-even point. So how many years would it take to recoup your investment? And those are often, I guess, requested. Is do you break even?
And in this example, there's no costs after year 5. But presumably sometimes there are like maintenance costs. Would that be factored in as well?
If it's incremental. So if there are additional maintenance needs, then it would be included. So those type of overhead, if there's no change with and without the project, then you'd exclude those. And I simplified a bit. So these are net cash flows, so already subtracted off the costs from the.
I see. Okay. All right. And so just make sure I understand this. So by meaningless, it means don't even bother trying to calculate an ROI if you don't have incremental increases in cash flow.
Right. Yeah.
Okay.
So you really need those offsetting increases for it to be meaningful. But calculating the net present value will give you a large negative number, and you understand the total cost over the entire time period.
All right. Well, thank you. This is very important to understand. Complex and lots of math, but I think this is really important for us all to be able to think about this perspective in working with health systems when we're designing something that we're expecting to change the way care is delivered. In Accords, we work a lot in health services research and thinking about changing the way care is delivered, changing models and systems and processes of care, often which have fairly substantial costs, from changing your workflow, changing the built environment in which care is delivered. And the huge investment in telehealth this year, for example, that there's a lot of costs associated with doing business in a different way. To be able to articulate, this is what it's going to cost you, and this is the future benefit you should be able to see. I really think we as health services researchers in particular need to think about this perspective. And when you're approaching health systems, hospitals, clinical practice, to say, will you test this with me? To say, and we want to learn about what the costs are to you, to your system, and when you can expect to start to see a return. This is obviously this is not something that I would do on my own. I would hire Rich. I would include Rich as a co-investigator on my grant, and in order to do this sort of thing. But really can't emphasize enough how important it is to think about this perspective, the perspective of the health system, the perspective of the payer, and not just say, but it's good. We see benefits, but also, and it's something you can afford. If $2 million is a drop in the bucket for their expenditures, then maybe they say, well, that's not that big of a deal for me. But if that's, a substantial amount of their regular operating expenses, and that's maybe something that they can't swallow or couldn't accommodate, and they may have many other priorities that they need to be working towards as well. So thank you so much for this. I think this is really great for us all to start wrapping our minds around. So thank you. Thanks everyone for attending, and please do your evaluation. Any final words, Rich?
No, yeah, thank you. And I would say telemedicine's a great example. It's been around for a long time, but it wasn't reimbursed very well. And now that it is starting to be reimbursed, we expect it to, expand quite, because you can make that business case to do it.
That's a really good point. And so you mentioned early on, sort of in passing, that sometimes it takes changes in policy that payers, that as a society, that the federal government needs to make a decision about what they're going to pay for and where they're going to place that, what they're going to place value in, and how they're going to reimburse to support things that actually do improve health. And so to be able to make that argument to policymakers is something we'll talk about another day.
Yeah. Well, thank you. Then
Thank you.
Please let me know if you have any questions. Those in the audience.
All right. Take care, everyone. Goodbye.